just catch Natalie up as she comes along. Projector's out. We got the other projector, so hopefully this will last the whole time. If not, we'll get out even earlier than expected. We didn't finish arterial blood gas lecture last time. We finished the first section of the mechanical ventilation side. So we're gonna cover arterial blood gases, and then we'll get into the gas exchange side, so pneumos, hemos, lung surgeries, and chest tube management. I would really pay attention to this arterial blood gas stuff. You are gonna get tested on it. Just throwing that out there, you are gonna have practice questions on arterial blood gases, so please commit this to memory as much as possible. Okay. I think you're next door. Yep. Alright, arterial blood gases and arterial blood gas interpretation. So if we remember last week, we talked a lot about the different type of vents, ventilator modes, what type of settings that we can put on the ventilator, that kind of stuff. And depending on what we see for this arterial blood gas, I can change up a lot of things on that mechanical ventilator, to affect my blood gases and hopefully improve my patient overall. So let's go back actually just a touch. And talk about the vent modes one more time. I know last night we talked about it in ICU, and the previous week we did in ICU as well, but just another refresher, okay? Tidal volume. How much air that I am breathing or pushing in to my patient's lungs at one time. The total amount of volume. So anywhere from like 350 to 450 milliliters of air. That overall amount. It's very patient specific. Larger, bigger type patients are gonna require a whole lot more tidal volume. These smaller patients are gonna require a lot less tidal volume. That just makes sense. Their lungs are smaller, lung sizes do vary. So your tidal volume is gonna vary. Your respiratory rate. How fast am I giving those breaths to my patient? So I'm giving it 16 breaths per minute or an 18 breaths per minute. How many times am I delivering breaths to my patient? FiO2. Don't get this confused with your PO2 that we're going to talk about in just a little bit with arterial blood gas. FiO2, it's a little bit different. The FiO2 is the pure amount of oxygen that I am putting into each breath, that my ventilator is delivering each time. So me and you breathing on room air is roughly 21%, and then it can go up from there. It can only go to 100%, and that's it. You cannot go any higher. 100% pure oxygen is the highest we can go. And so it can be anywhere in between those kind of ranges. Usually when we get to 30 to 40% FiO2, that's when we're gonna start talking about the weaning process and hopefully be able to extubate or remove that endotracheal tube from our patient and putting on something else, okay?
What was the percentage?
30 to 40, and then 100% is gonna be your max. That's as much as we can put of pure oxygen in there. All right, your PIP, your peak airway inspiratory pressure. Don't get that confused with your peak right here. A little bit different. Your PIP, peak airway inspiratory pressure. How hard is my ventilator trying to work to overcome that resistance to deliver that breath of air? How much pressure it takes, how much force it takes. All right, so if I have my patient biting, coughing, is real anxious, he's gagging on that tube, my ventilator has to work a whole lot harder to deliver that breath of air, to deliver that tidal volume into my patient's lung, because it's having to fight against so much resistance. So my PIP, my peak airway inspiratory pressure, is gonna be a lot higher when I have those types of issues. Other things, maybe they have stiff, non-compliant lungs like COPD, asthma, maybe they have COVID-19 type lungs or ARDS, or acute respiratory distress syndrome, those types of conditions. Maybe they do have pneumonia and they have a lot of secretions and they're coughing up a lot of mucus. Maybe they have a mucus plug that's causing some of that resistance against that PIP, all right? So how much resistance that my ventilator is going to overcome. I can also have on the low end as well. So things like an airway leak. Maybe my ventilator tubing on here on the other side got disconnected from my endotracheal tube, and so now my ventilator is just blowing that tidal volume out into the atmosphere, out into the air. So it's not meeting a whole lot of resistance, therefore my PIP is gonna be a lot lower. Maybe my endotracheal tube got dislodged, it's no longer in the right spot, and so it's not meeting as much resistance. One more thing, good possibility, this could be the balloon at the end of your endotracheal tube. Maybe it has deflated or it has popped, so it's not creating that good adequate seal right above that carina and to allow us to blow that breath of air into their lungs. So if it's not meeting resistance, it's pushing that air up and out instead of down further into those lungs. So that could be another option for a low PIP. All right, next one, your PEEP, your positive in expiratory pressure. How much pressure or force that I'm pushing into their lungs at the end of expiration. I need a little bit of positive airway pressure to keep those alveoli open as long as possible to create that oxygenation and that CO2 gas exchange. The more PEEP that I have, the longer that my lungs stay open and fully ventilated, the more alveoli recruitment I can have. So the more alveoli I have, the more gas exchange that occurs. If I don't have enough PEEP, then I start to lose my alveoli recruitment, and then my alveoli are starting to get a little bit sticky. They collapse down on themselves, something called atelectasis. And so I cannot use those alveoli in that oxygen CO2 gas exchange. And so I need to have a significant amount of PEEP, or for my patient, it's going to be titratable, to open up their airways, to keep them open throughout the whole ventilation process. For your PEEP, 5 to 6 is roughly a pretty good range. When you start to get to about 15 or higher, that's when it's going to cause some issues. So we can have some of that barotrauma or that volume trauma where we're causing these injuries to these lungs. With your PEEP as well, remember, we're causing a lot of increase in that intrathoracic pressure. There's also the heart that's involved in that thoracic cavity. The more pressure that I'm creating in that space, the more pressure is being compressed on my heart. So that's overall going to decrease that cardiac output. So I'm going to have a decrease in blood pressure. I may have a decrease in heart rate for a while because my heart is trying so hard to expand out, allowing for those chambers to fill up. And if they're not allowed to fill up, that next pump or that next contraction, I'm not sending forward more blood into circulation. So that's why it's decreasing that cardiac output overall, okay? And the last one's gonna be your flow rate. How fast I'm delivering that breath of air into my patient. How fast I'm delivering that tidal volume to my patient, okay? Questions about the ventilator settings or terms? Just real quick, fast, and a hurry. All right, modes of mechanical ventilation. Remember, this is really not within our scope of practice. It's good to know these things, good to know the terms, good to know what these modes mean. But we're not gonna go in there and change these things or have significant changes just on our own. All right, there's gotta be a physician order. The physician's gonna work real close with a respiratory therapist. And if you have a good respiratory therapist as well, they're gonna work closely with you. So it's gonna be this big circle. But it's up to the physician on what type of settings, what type of modes, what type of changes are going to occur with your ventilator. For your modes of ventilation, we have 3 ones that we're gonna focus on. There's way more options out there, but I want you to focus on the 3 that's on this slide right here, okay? Your top one, the one that's most invasive, is gonna be that assist control ventilation. Assist control ventilation goes into 2 subcategories. So you can either have pressure control, assist control ventilation, or you can have volume control, assist control ventilation. So you'll see that a lot of times on your ventilators. So up here at the top, it says VCAC, volume control, assist control ventilation, or you can see it down here at the bottom too. And so that's what I'll tell you. With my assist control, I have a set tidal volume. So let's say 450 for instance. I have a set tidal volume of 450, and then I have a set respiratory rate, let's say of 12. Every time my patient receives a breath, for those 12 breaths, he's gonna get a tidal volume of 450. Now, if my patient breathes over it, say he's breathing at like 14 times a minute, those 2 extra breaths that he initiates on his own, that the ventilator is not delivering to him, he's also gonna get a tidal volume of 450. That's gonna be your sys control. Remember, it's the max assistance. So every time he takes a breath, whether it's the ventilator doing it or him doing it, the tidal volume is gonna be the exact same. Our next one down is gonna be our SIMV setting, your synchronized, intermittent, mandatory ventilation, all right? With this one, it's our next step down from our assist control. Remember, we're trying to give our lungs a workout, trying to get them a little bit stronger. We're trying to wean them off the max support. The lungs get lazy, they get tired. So we've got to get them working out, get them a little bit stronger before we pull this endotracheal tube out. But with your SIMV setting, again, I have that set respiratory rate. So let's say 12 again. And then let's say another set tidal volume of 450. Those are my set values. So for every 12 breaths, he's getting a tidal volume of 450. Now, if my patient overbreathes the vent again and he wants to do more breaths than 12, so let's say 14, those 2 extra breaths, here's the key, he's gonna be able to do his own tidal volume. That's gonna be your difference with AC versus your SIMV. He's not gonna get that complete tidal volume, that 450 tidal volume. He may only pull 100, he may only pull 150 of tidal volume. It's whatever he wants to do. I'm trying to give him a chance to get those lungs a little bit stronger. That's my goal with SIMV. Does that make sense for everybody? Okay. Last one, pressure support. Pressure support, or you can hear it called CPAP mode, or breathing trial. There's a lot of options out there, just so whatever your facility is gonna call it. But pressure support, it's basically what it says. I'm giving them a little bit of pressure. Keep that airway open, and so they can initiate all the breaths, they can do all the breathing on their own. My patient has to be fully awake, has to be fully participative in this trial, or in this side, or in this mode. Because he's got to initiate all those breaths. My ventilator is not gonna do any of the work for him. All right? Just a little bit of pressure, open up those airways, allow him to do whatever he wants. All right? And we can go in between any of these 3 at one time. And hopefully our goal is to be in that pressure support mode for a while, get an arterial blood gas, see what those values look like. If they're good values, we like them, then we can extubate them or pull that endotracheal tube out and then put them on some other type of supplemental oxygen if they need it. So they might go to a high flow, they might go to a BiPAP or a CPAP at night. So there's other options out there, okay? Questions about ventilators, ventilator modes, settings? Okay. Let's get into the second half of this lecture. Somewhere over here. Arterial blood gases. So remember, with arterial blood gases, the big things we're going to look at is our pH level. What's our normal pH? 7.35 to 7.45. Good. We're going to look at our CO2 as well. So 35 to 45. We're also going to look at our bicarb. 22 to 26 is going to be our normal value for that. All right. And then now I'm going to introduce another setting for you as well, your PaO2. How much oxygen is running around in that blood? That PaO2. Don't get that confused with the FiO2 or your SpO2. There's a lot of O2s in there, so make sure you know which one you're talking about. All right. So with your PaO2, that percentage or concentration, amount of oxygen that's in my blood, it can go as high as it wants to go. Our normal readings that we want is going to be roughly in the 80 to 100 range, but it can get up to 400, 450, 500. It can get way on up there. And that's something we can think about with oxygen toxicity. We don't want those that high. So if I start to see those 450 PO2s, then I can bring down my FiO2, or how much pure oxygen my ventilator is delivering, and then I can titrate it down from there based off of my blood gas, okay? And then of course you have your O2 sat, we want it 95 to 100. Do not worry about this one at the top. Just remember these sets right here. Okay. We're doing arterial blood gas interpretation. How are we going to assess? What are we going to look at? How do we begin with it? First things first, let's look at our pH level. All right, determine if it's acidic or more alkaline. The lower my pH value is, the more acidic it's going to be. The higher it goes, so if you get like a 7.45 or higher, the more alkalotic it's going to be. Once I determine if it's acidic or alkaline, now I can move on to my next step, my CO2 level. Determine what that's going to be. The higher my CO2 level, so I get 45, 46, 47, the more acidic it's going to be. And then on the lower end, the more alkalotic it's going to be. So it's kind of an inverse relationship with your pH level. So remember that. And then third, we're going to look at our bicarb level or our HCO3 level. Your HCO3 level is going to follow your same concept as your pH level. The less bicarb I have, the smaller amount, so like a 20, 21, the more acidic it's going to be. And then the higher your bicarb goes, the more alkalotic I'm going to be. And then lastly, we're going to talk about compensation and uncompensation type conditions. And that's the next step that we're going to talk about with our blood gas interpretation. So you should already kind of be familiar with respiratory acidosis, respiratory alkalosis, the metabolic, and the acidosis or alkalosis. But we're going to take it a step further and talk about compensation versus uncompensation. All right, this slide is what I was just referring to. So the lower your pH goes, the more acidotic we're going to get. The higher it goes, the more alkalotic we're going to be. Same thing with your CO2 and your bicarb. So refer to this chart. Don't get confused. Look at this. Your numbers are switched, all right? So 45 or greater is your acidotic side. This doesn't read 35 to 45, so that's that big change right there. All right. This slide is going to show us our normal values for our normal types of blood gases. Just the real basic interpretations of this. So this is just going to show you your respiratory acidosis, the alkalosis, and the metabolic side as well. So this would be a good chart for you to memorize as well if you're unfamiliar with it or a little rusty. I know we haven't talked about blood gases in a while. Okay. As far as interpreting these, I use the Rome method most often. There's several methods out there, and I apologize because I cannot teach those other methods. I can learn them if you need me to. If you have another method that you like, let me know, email me, pull me to the side. I can learn it and help teach you through it. Dr. Fuller is there as well, and he does all kinds of different stuff that seems out there to me, but he loves it, and some people love it too. So if you really need help, please reach out, okay? I like Rome method. Respiratory opposite. So your pH level and your CO2 level are gonna be opposite of each other. You're gonna have an inverse relationship with each other. If your pH is low, your CO2 is high, that's gonna be your respiratory acidosis or alkalosis, depending on which way we fall. And then your metabolic is gonna be equal. So that's gonna refer to your pH level and your bicarb level being in the same direction, whether it be too high or too low. And that's what the Rome method is gonna represent, okay? Now let's think about these things for a little bit. Respiratory acidosis. What kind of things are gonna cause that? So this is a pretty good chart. So respiratory acidosis, let's think about it. What's my pH level doing? It's too low, right? All right. And then for my CO2 level, it's gonna be what? Too high. All right, so that's respiratory acidosis. So things that are going to cause me to hypoventilate, things that are gonna restrict my airflow, causing me to retain That's CO2, driving that CO2 level up and driving my pH level down. That's what respiratory acidosis is gonna represent for us. So things like COPD, do COPDers retain CO2? A lot of it, all right? That's why a lot of time they come in that COPD exacerbation, we put them on the BiPAP mask, let them blow off a little bit of CO2, they wake up, they're fine, they go home, all right? Some type of airway obstruction. Am I able to move that air out freely like I'm supposed to? No, I'm not. So that CO2 level is gonna rise. Other things, sedation, opioids, it's gonna all cause that hypoventilation, making that CO2 level go up, okay? Let's look at the other side, respiratory alkalosis. So my pH level is gonna be too high, right? Right. And then my CO2 level is gonna be too low. So things that is gonna make me blow off more CO2, make me breathe faster. So if I'm hypoxic, I'm trying to breathe a lot faster, trying to get more oxygen in. I'm starting to panic a little bit, so I'm gonna hyperventilate a little bit, and that's gonna cause me to blow off more CO2 than I need to. Same thing with that anxiety, that fear, that pain. All those things are gonna drive my respiratory rate up, therefore driving my CO2 level down. All right. Other side, metabolic acidosis. So remember, pH level is gonna be low. Bicarb is gonna be low as well. So you got a lot of options here. Lactic acidosis, renal failure, diarrhea, all right? On the other end, your metabolic alkalosis. pH level is gonna be super high. I'm getting rid of a lot of that acidity from that pH. That's these kind of conditions that I'm gonna think about here. So my pH is high and my bicarb is high as well. My HCO3 is high. So things like vomiting. If I put down an NG tube and I hook it up to continuous suction, I can cause that metabolic alkalosis. I can pull out electrolytes out as well. Hypokalemia. Several options out there, okay? So let's practice some basic ABG interpretations. Patient presents with a pH of 7.3, CO2 of 50, and a bicarb of 24. What is the likely diagnosis here? I hear respiratory acidosis. Everybody in agreement? Yes. Okay. Awesome. Respiratory acidosis. All right, so my pH level is 7.3. That's below normal, so my arrow is going to go down. My CO2 is 50. That's above that 45 mark, so my arrow is going to go up. So I'm already having that unequal, that respiratory opposite. So I have that respiratory acidosis. Questions about that one? That makes sense? Okay. Let's look at another one. Patient has a pH of 7.48, CO2 of 30, and a bicarb of 24.
Respiratory alkalosis.
I hear respiratory alkalosis. Everybody agree?
Agreed.
Everybody else don't like Natalie's answer? Everybody likes Natalie's answer. I like Natalie's answer as well. Respiratory alkalosis. So our pH is 7.48. That's a little high. Right past that 7.45 mark. CO2 of 30. So that's a little low. And then our bicarb is normal. All right, so we've got opposite pairings. Remember, pH too high, alkalosis state. pH 7.5, CO2 of 35, bicarb of 30.
Metabolic alkalosis.
I hear metabolic alkalosis. Everybody in agreement? Good. So this one's different than the respiratory ones. So remember, metabolic is equal. All right, our pH is 7.5. That's abnormal, right? That's a little high. All right. CO2 of 35. Is that within normal range? Yep, so I don't have to worry about that one. Bicarb of 30. That's too high too, is right? So they're heading in the same direction. My pH and my bicarb are both high. So it's going to be our metabolic alkalosis. Patient presents with a pH of 7.32 and a bicarb of 15.
Metabolic acidosis.
Metabolic acidosis, good. If I don't give you a CO2, is it going to be respiratory related? Probably not, okay? So think about that. So both low values on that end. pH 7.45, CO2 of 40, bicarb of 22. Sam says normal. Everybody agree with Sam? Yep, I like Sam's answer. So remember your normal reference ranges, and everything is going to be within that normal reference range, okay? There can be some normal answers, so don't go hunting for those zebras and thinking that something's supposed to be wrong. If it's right, it's right. If it's normal, it's normal, okay? Don't overthink it. I think I got two more. 7.48 pH, CO2 of 28, bicarb of 24. What's that? Respiratory acidosis. Alkalosis, okay. pH 7.48. Remember, the higher it goes, the more alkalotic it's going to be. CO2 28. All right, that's a little low. So pH is too high, CO2 is too low. Respiratory is opposite. Bicarb is normal, so we don't have to worry about it. So respiratory alkalosis. And then, should be one more. pH 7.32, CO2 of 60, and a bicarb of 30.
Respiratory acidosis.
Respiratory acidosis, good, I like that. pH is too low, CO2 is too high. That's pretty straightforward, right? Everybody get that? Pretty comfortable with that? Please be comfortable with it. If you're not, come to me. We'll talk through it, okay? This is going to be on the exam, just like these types of questions right here, okay? Now, let's take it a step further. Let's talk about uncompensated versus compensated type of ABGs. Uncompensated. My patient's buffering mechanism has not been given enough time to take my pH back to a normal level. All right? Either hasn't tried at all, or it's starting to try, and my pH hasn't gotten there yet. You can break down your uncompensated into two different ways. Uncompensated, just uncompensated altogether, or partially compensated. So with uncompensated, none of my other values have changed, have gotten out of range to hopefully attempt to bring that pH level back into normal range. That's our uncompensated. Partially compensated, one of my values, either my CO2 or my bicarb, has changed, is without of normal range now, but my pH hasn't had enough time to get back in that normal range. So that's your difference, your uncompensated versus your partially compensated. With our compensated, on the other side, pH has gotten enough time to get back within that normal range, but my other values are still going to be off. They're still trying to recover from trying to get that pH back into normal range. Because that bicarb and that CO2 has to correct itself in order for that pH to get back in normal range. But it just hasn't had enough time for all three values to get back within normal range, okay? When I'm looking at the uncompensated versus the compensated, I've got to look at the whole patient condition. So I may give you a little bit more information. Maybe my patient is a non-compliant COPDer. Alright, so when you think of COPD, what are you thinking about already? Respiratory acidosis. So that's already half of that problem worked out. More than likely, my patient is in some form of respiratory acidosis. Now I have to look and see if it's compensated or uncompensated at that point. So that's that primary disorder. What's causing that pH to jump off one way or the other? And so it can be a little bit difficult if my pH has gotten back into normal range to fully determine what deciding factor it is. And so we really break down our pH reference range of 7.35 to 7.45 in half. If it's on the lower end and my other values are abnormal, then I can consider it either metabolic acidosis or respiratory acidosis. If it's above that 7.4 range, that's on the higher end, remember, and so that could be something like a respiratory alkalosis or a metabolic alkalosis. That's going to make more sense when we start doing some of these, okay? All right, this is a big chart here. That's the same piece of paper that I just gave everybody. Natalie, you should have one somewhere over there, okay? Same chart. It's got all of your disorders, so your respiratory acidosis, alkalosis, your metabolic acidosis, and alkalosis. And then it gives you uncompensated, partially compensated, and you're fully compensated. And then it'll give you all your reference ranges that you're gonna need to know, all right? This is a big chart to memorize these numbers. If you can start thinking about it with the Rome method and how you're gonna interpret it, you won't have to necessarily get specific with these reference ranges. If you have a hard time with that, if you commit this to memory, you can do it that way too. Either way. I would highly, strongly encourage you, as soon as you get your scratch paper on that test day, write all your reference ranges out. You can even write respiratory acidosis, this is what I'm looking for, my reference ranges. And you go through and list out all your reference ranges. Because you're gonna forget some of this stuff on test day. Let's do some practice questions. This is how we're going to learn our compensated versus uncompensated. Patient presents with a pH of 7.25, CO2 of 60, and a bicarb of 27. What is our primary disturbance? You want me to work the first one out, and then we go from there?
Yeah.
Okay. So pH, what's my pH? 7.25, okay? Is that high or low? That's low, right? So I'm gonna put a little down arrow because it's too low. All right, what's my CO2?
60.
60, okay? Is that too high or too low? Too high, all right? And then my bicarb, 27.
Which is high.
Is that too high or too low? High, because it's right above that 26 value, right?
So is it fully compensated?
All right, now, a pH is out of whack, right? So it's too far down. CO2 is too high up, all right? So that's gonna be that respiratory acidosis component, all right? I can't have too low a pH and too high a bicarb to make a metabolic acidosis. So it's gonna mark that one out completely. The only thing that I can make out of that is that respiratory acidosis, because I have too low a pH, too high of CO2. So respiratory is opposite, all right? So I can go ahead and write respiratory acidosis out there. All right. Remember, too low pH, the more acidic I get. The too high of CO2 I get, the more acidic I get. So that's how I'm getting that respiratory acidosis. Now, let's talk about this one, because this is out of range too, our bicarb level. All right, so my bicarb is trying to change. It's trying to help out my pH level because it's recognizing, hey, my pH is too low, I gotta do something about it. Remember, the higher our bicarb gets, the more alkalotic it gets. So my bicarb is trying to raise up to be more alkalotic to help buffer this pH to get back in range. All right, so am I trying to compensate? Yes, because my bicarb is different. It's without a range, all right? Now, is my pH in normal range?
No.
No, so it has not fully compensated yet. My body has not had enough time to get my pH back in normal value. So if my pH is not normal, it's gonna be partially compensated respiratory acidosis. Okay? Does that make sense?
Yes.
Okay. Hopefully I worked it right. We'll see what I put on the acidosis. Partially compensated respiratory acidosis. Good. Question 2. pH of 7.45, a CO2 level of 30, and a bicarb of 20. Let's take a couple minutes. Let's work on it. Everybody still working? Everybody ready? Yep. Okay. Anybody want to venture an answer?
Fully compensated respiratory alkalosis.
Fully compensated respiratory alkalosis. Is she right?
Yes.
Everybody think so? Okay, good. All right, let's talk about it. pH 7.45, high or low?
Normal.
It's normal, okay? Well, let's talk about it another way. Which way is it normal? It's high normal, right? So it's just out of range of being too high because it's 7.45. CO2 of 30,
Low.
low, right? Bicarb of 20,
Low.
low. All right. So my respiratory are different. I got too high of a pH, technically, because it's just high normal. My CO2 is too low. Now my bicarb has got to change to make a difference to hopefully buffer my pH. Remember, my bicarb gets too low, the more acidotic it gets. So I'm trying to create some more acid to bring that pH back down. So I already know that it's respiratory alkalosis, so I can write that down. Now, is my pH within normal range? Yes. So if it's in normal range, then it's compensated. If this was 7.46 or higher, it would be partially compensated because my bicarb has changed to hopefully compensate for my pH, but my pH has not had enough time to get back within normal range. You can only have full compensation when your pH is back in normal range. If it's not normal, then it's not fully compensated. You can go ahead and mark those answers out. Okay? pH 7.34, CO2 of 50, and a bicarb of 30. Drew, what'd you get?
Partially compensated respiratory acidosis.
Okay. B, partially compensated respiratory acidosis. Everybody agree? Okay, good. So pH 7.34, high or low? Low, right? Okay. CO2 of 50, too high. And then bicarb of 30, too high. Alright, so I have unequal pairs here, so I can always mark respiratory acidosis. Is my pH back in normal range? No, so it cannot be fully compensated, so it can't be D or A. Has my bicarb changed? It has, so it's partially compensated. What if my bicarb was 20? Uncompensated, right? It is different. It is abnormal, but it's not heading in the right direction. Remember, my bicarb has to be elevated to be partially compensated respiratory acidosis. So if you see just because it's abnormal doesn't mean it's necessarily partially compensated. All right. So please know those values. I got several of these. So. pH 7.45, CO2 of 40, and bicarb of 30. Everybody got it? Still working? Yes or no?
No, I lied. That's not what it is. It's B, sorry.
Sam says B.
Yeah, that's what it is.
After she said C. So is it C or B?
It's B.
It's B. I like fully compensated metabolic alkalosis. Good. All right. This one's a little bit different than the other ones we've talked about. So let's do it real quick. 7.45. That's normal, right? All right. Is it on the high side or the low side of normal though?
High.
High side. Good. CO2 of 40.
Normal.
Normal. Yeah. Sorry. Ooh, that was really. Bicarb of 30.
High.
High, right? Okay. pH 7.45. It's on the high side of normal. My CO2 is right dead in the center. Remember, I can't have too high of a pH and have respiratory acidosis or alkalosis. These arrows cannot go the same way. And so that marks all my respiratory stuff out of the way. Metabolic side, I can have two high values or two low values. So my bicarb is 30, that is a little high. Remember, 22 to 26 is gonna be your normal bicarb load. So I got two high values. My CO2, it didn't really change a whole lot, but it has compensated enough to buffer to get my pH back in to normal range. So if my pH is in normal range, then I can have that fully compensated metabolic alkalosis.
Or can it be that you're not out of range yet?
That could be it too. So I mean, it's, you're kind of,
If you go in the wrong direction.
exactly. Yeah. For this purpose, it's gonna be compensated already, but yes, you were right.
This could be not there yet.
It could be uncompensated or metabolic alkalosis, that's heading in that direction, yes. Okay.
Let's not make it too complicated.
Well, yeah, we're not gonna get that far, but yeah, Chuck is correct on that, for sure. All right, do I have to worry about compensation on this one? No, because it's not in any of the answer choices, right? So don't worry about compensation, all right? Don't, if I don't ask for compensation in the answer choices, don't worry about it. Just do what the blood gas says, okay? So pH is 7.3, too low or too high?
Low,
Too low, right? CO2 is 70,
high,
too high, all right? Respiratory acidosis. Well, let's work it up too. CO2, or bicarb of 30. Is that too high or too low? Too high. So we can have partially compensated respiratory acidosis because my pH is not back within normal range. Okay? But if I don't ask for compensation, don't click anything about compensation. All my answer choices don't have anything about compensation, so don't worry about it. All right? Somehow they got in there. Keep going. pH is 7.4. Is that normal? Okay. CO2 of 38. Normal, right? Bicarb of 24. Normal, all right? Don't go chasing zebras. It's none of this other stuff. It's a normal ABG, right? Okay. Don't freak out when it's normal. More than likely, you're not gonna get a normal ABG on the test though. Just throwing that out there. But don't freak out if it is. That means you're doing something right. I think this one's actually supposed to work, so. pH of 7.29. Low, right? CO2 of 55.
high.
High. Bicarb of 22.
It's technically normal, but I'm low.
Alright, so normal. Alright. What, based off of this, am I considering? Respiratory acidosis, right? pH is too low, CO2 is too high. Now, do I have respiratory acidosis on here? I do, but I have compensated versus uncompensated. Now, has my bicarb changed at all to compensate or to buffer for that low pH? No, it has not risen at all. It's not above 26. So if it's in normal range, then my body is not compensating whatsoever. So C right there, uncompensated respiratory acidosis. Does that make sense? Okay. Question 8. pH is 7.47. That high or low?
High.
High? Alright. What else I got up there? CO2 at 28?
Low.
Low. Good. Bicarb of 24. That's normal, right? Alright. So based off of this alone, what do we have? Respiratory alkalosis, right? pH too high, CO2 too low. Now, has my body had any time to change my bicarb level? No. So it's not trying to compensate for that pH being too high. So again, uncompensated respiratory alkalosis, A. I think I got 2 more. pH is 7.52. Bicarb of 50 or CO2 of 50, bicarb of 30. So pH is too high, right?
Mm-hmm.
Alright, what's my CO2 level?
High,
High. Bicarb level?
high,
High. 3 high values. Alright. Now, can I have an equal pH and an equal CO2 and have respiratory anything?
no,
No. Alright. Do I have an equal bicarb and an equal pH? I have a too high pH, I have a too high bicarb. So I got metabolic alkalosis.
partially compensated.
Alright. Now, the higher my CO2 goes, is more what? Acidotic or alkalotic? Acidotic, right? Good. So, I'm trying to produce more acidity with my CO2 being too high to compensate for my pH being too alkalotic. But is my pH back in normal range yet?
No,
No. So partially compensated metabolic acid or alkalosis, sorry. And that one's kind of an easy one to remember. If you see 3 up arrows, then you know it's partially compensated metabolic alkalosis. So you can see those trends too. If you just remember 3 up arrows, partially compensated, I'm fine with that. But please try to remember the values too, okay? pH is 7.3, so that's too low. CO2 of 55, too high, right? Bicarb of 24. All right. I got respiratory acidosis, right? And then is my bicarb trying to help out at all? No. So uncompensated respiratory acidosis. Right. That should be it. Questions about compensation versus uncompensation? If we went too fast, please come and visit me, email me, Zoom, we can do anything. Get you these concepts in. Because these are going to be on the exam, guarantee it. Okay. Let's take 5 minutes.